transforaminal approach, which is very different than most spine surgeries, which means we go through a natural opening that's already in the spine to fix the disc herniation. Every other spine surgery done requires removing the bone in the back of the spine to fix the disc. So this surgery preserves all the spine and bone and prevents instability as a result. Our patient is awake. Dr. Duke here, we're going to get started, okay? So she has a herniated disc at L5-S1 and L4-5 on the left side, causing left leg symptoms like sciatica, numbness. She used to have more pain, but now the compression is so severe, she's lost the pain feeling and mostly has numbness. All right, we're going to get started, okay? You're going to feel my hand on your back. I'm just pushing around, feeling for things. I'm palpating for the iliac crest. All right, I'm going to give you some numbing medicine, okay? You'll feel a little stick and burn, and that's normal, so don't freak out, okay? All right. Now I'm going to keep you awake in the beginning, and then we're going to put you to sleep. But once I get to where I need to go, okay? So I just need you to be patient with me in the beginning. All of our patients for the lower back and the thoracic start out awake. With the cervical spine, we put patients to sleep right away. And I need the patient awake because she's going to help me. We did 4 cc's. Watch the needle. She's going to make sure, she's going to kind of help me guide me to the problematic area, which is the 2 discs. And I need her assistance to do that. All right. So I want to get over pretty medial. I want to start as lateral as possible, which is what I'm doing. Shot. I'll be talking to my team, lateral view. Why is your AP so bad? Yeah. Alrighty. So we're going to use our X-ray machine to get into the right place. It's this wire right here that's in the way. Okay. Did you raise the bed? All right. So what we're doing is we're getting the patient's. That's good. That's good. Not too much. We're getting the patient positioned properly. It's too much. Maybe you can drop it about 1 inch. Let's try that. You're still too far north with your fluoro. That's good. That's good. Shot. So I think you're too high with the fluoro. Drop the fluoro to the floor, and you need to wag. You're way off with the wagging. You need to bring my side probably north. Bring your base south. Shot. That's better. We can drop the table a half inch, sorry. Good. All right, let's see if we can't get a better wag on there. It's very close. It's very close. So one of the things to notice about this patient's X-ray is she's got pretty short pedicles. I think you're going to have to rotate like this. Your side's too high. I think my side has to come up a little bit. Let's see what that does. Yeah, let's see. I don't know if that made it better or worse. Yeah. She may be like not laying flat on the table. Yeah. She has short pedicles. Try a little more. Let's see if it gets better or worse. Just about 1 degree. That got hard to say. Maybe worse. Try a little more and let's see if it gets even worse. Then we'll go the opposite way. Shot. That looks worse. Go the other way. So we're trying to basically move the X-ray machine around I'm the patient. Keep going or something. We're still off. Shot. Luis, is the patient flat?
Yes, sir. Yes, sir.
I feel like we're going, it's just almost like it's getting worse. Let's try a little more just to be sure, and then we have to go back the other way. All right, let me have it. Where were you going, up or down on my side? I think we need to go here. Shot. We're seeing way too much of the lumbar spine. Shot. Can you zoom that in a little better? Yeah, you should always be zoomed in, Jordan. Why are you not zoomed in? Huh? Huh? I'm sorry? Yeah, you can't forget things like that, Jordan. It just really hurts our what we're doing here. Drop the table, please, ½ inch. All right. Shot. Shot. It's definitely getting worse. Shot. Yes, you have a question, Sonny? Lock it in.
No, sir.
Are you comfortable, ma'am? All right. We're just getting everything set to get started here, and you let me know if you feel any pain, okay? The important thing is that if you do feel pain, you tell me and just say ouch, but don't try to get off the table. Shot. Just say ouch, and I'll do something to make it more comfortable for you, okay? Shot. 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 Are you having any pain? Shot. All right. Huh? It's odd. Shot. Let's go AP. Maybe too lateral. Watch your head there. Jordan. All right. Let's go. You're really not AP, so you don't see the spinous process is not in the midline? It's a little better. Okay, go back to a lateral view, please. Are you comfortable? Shot? Shot? It's definitely facet. Shot? Be a little bit higher. Shot? Shot? You feel anything? Where? Huh? Shot. Okay. I think we're in the herniation. Shot? Are you uncomfortable? Where do you feel that? Okay. All right. Good. Let's get an AP. I remember you said it's mostly leg pain, right? That you get? Or numbness, leg symptoms? Do you have much back pain normally? Yeah. All right. That looks good. All right. Let's go. Actually, you really need to be more towards my side. All right. We're halfway there, okay? I'm going to be able to put you to sleep soon, but I still need your help just for a little bit longer. Blood pressure's good. Yeah, perfect. Love it. She doing all right? Okay, good. Okay. Well, we've got one down, and hopefully we'll have the other one soon. Okay. Shot. Why don't you go lateral? All the way in, all the way in. I shouldn't have to tell you. All right, good. Shot. A little overexposed. Okay. Let's see. I think that's pretty good. Yeah, she does have short pedicles at L5. If you want to add that to the post-op diagnosis, that's fine. Shot. Just don't know why I can't see the pedicle better. Jordan, any idea? The L4 pedicle? Shot. 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 AP. Any pain in your leg? Any in your back? Right now? You're comfortable? All right. All right, it's good. Lateral. So the first step in the Duke laser disc repair surgery is to access the herniated disc and annular tear on the side that we want to repair through a transforaminal approach, and that's what we're doing right now. Good. It's overexposed. Okay. Shot. You can feel the herniation. Shot. All right. Are you comfortable? Yeah? Have you ever watched one of these surgeries before? Yeah. Do you know what happens now? What happens? You're right. Smart lady. Any pain? How bad on a scale of 1 to 10? What's the highest it got? 7.5. Nothing higher? Okay. 7.5? I can't hear it. Okay. But the worst it got was 7.5. Is that where you typically get your back pain? Yeah. Okay. So 5.1 concordant, 7.5 out of 10. We won't need it. But thank you. Yes, it's good to always have it, right? You comfortable? How bad on a scale of 1 to 10? 9 out of 10, is that where you typically get your pain? When you get back pain? But is that the area in your back? Yeah. All right. So concordant, 9 out of 10 at 4-5. So the good news is when you wake up, we'll be done, and both of those areas that caused you pain will be fixed, and they won't be causing you pain anymore. How does that sound? All right. Will you count from 1 to 100 for me, out loud? Count from 1 to 100 out loud. All right, we've got the needles and the 2 discs. They're in perfect position. We've done the dye injection in the disc with the 2 types of dye. One is contrast dye for the x-ray so we could see it. And you can see there's tears at both discs. The other one is the blue dye, methylene blue. Sorry, indigo carmine blue, not methylene blue, indigo carmine shot. And bring the fluoro towards me a little bit. Okay. We're going to start at L5-S1 shot. I can see the guide wire there. It's at the front of the disc. We don't want it to go any further in. I'm taking the needle out, and then we're going to run the dilator, which actually doesn't cut tissue. It actually spreads tissue. Take a look at this thing. It runs right down the guide wire, and it just spreads the muscle open. It doesn't cut the muscle, doesn't cut the fascia. It literally just spreads it open, you know? So, and then when we're done, we take it out and the tissue goes back. So that's why the surgery is so wonderful and people recover so quick. There's no cutting. The only cutting we're doing is the skin. And people heal up real quick from skin cuts. So her herniation is real medial, and I want to try to get as medial as I can. It's always a challenge when you do transforaminal to get medial. And the secret is to go a little more lateral, but the more lateral you go, the higher risk you have of getting into something you're not supposed to. So, shot. The real, difficulty here is to get as medial as possible without injuring anything inside the pelvis or abdomen. And I think we're fine. I could feel us pass through the muscle layers. I feel a huge herniation here. So, all right, ready for me? So we're going to enter the L5-S1 disc shot. I want to keep this moving in the same direction as the guide wire. You don't want to force the guide wire. I can feel the herniation pushing in right there. That was amazing. I'm going to take the guide wire out because I don't want to trap it. Take this. Let me have it. Shot. Shot. Okay. Shot. All right, so she has a really big tear. This has come back a little bit. I think we're okay. Let's get a shot. Let's get an AP. It's a little more lateral than I want to be. Let's go back to a lateral view. I'm not really happy with that. I want to try to reposition everything. We can keep her asleep if she's asleep comfortably. So we're going to start with a needle. We're back to a lateral view, right? All right. And I could see the back of the vertebral body. Why don't you give me a little arc, about a couple of degrees, see if that gets better shot. Now the other direction, shot. Can't really tell. That's probably okay. Let's leave it there. Can you move north a little bit? Shot. The problem is her spine is not lined up perfectly. She has some scoliosis at the bottom. So even if we line up the L4 pedicle perfectly, the L5 is not lined up perfectly. Let's try adjusting the arc again. I don't know why. Is she not flat? Shot. Let's see what that does. See, the L4 looks good. L5 I think looks a little bit better. Alright, so I have to go through the same incision, and I'm targeting the, once again, the L5-S1 level. I wasn't happy with where we were shot, so I'm coming up on the facet here. Shot. That's better. Now I gotta sneak around it. Shot. Shot. Almost there. There we go. Shot. Let me have control. Shot. 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 All right, let's lock that down. Not ready yet. Shot. Shot. That's looking good. That's the only thing I don't like. Shot. I mean, either this is the biggest tear. Let's get an AP, or she's severely rotated. definitely has some kind of posterior, like a spina bifida occulta. You can see where spinous process at L5 is not entirely normal. Is that it right there? Did you take another AP? You can even see the pedicle doesn't seem normal at L5. All right. Seems that her spine is more rotated towards me, left side anterior. Let's go back to a lateral view. It's kind of blurry. It's not bad. Where does she feel that? Where does she feel it? In her back or her leg? In her back or her leg? Her back. All right. Right there, shot. There's the facet, shot. 100%. I need to sneak around the facet. That's that, shot. And there's just, where do you feel it? Where does she feel it? That feels like the herniation, shot. Is so far off on this view. Give me an AP. Move it more towards me. And shot. So that's just at the disc. And yet on the lateral view, it looks totally different. Bring it towards you a little bit. You're not centered. Come on. Shot. All right, so there's the spinous process of 4, 5. 5 is abnormal, but that is at least pretty close to the midline. And this thing is hitting on the disc so far from midline right now. And yet, on the lateral view, it looks like we're anterior. Can you go back to a lateral, please? Go lateral. Good. Now release the orbit here. Shot. No, makes it worse. Shot. There we go. It's getting better. Is she really that rotated at 5-1? Shot. I don't know that that made it any better. I think I overshot it. Shot. Is this moving at all when I move it? Shot. 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 Let me have this. Shot. Huh. That's definitely better. I can see a foramen. Shot. Why am I hitting something bony? That's the herniation for sure. You feel anything? Shot. Well, the problem is L5-S1 is unlike every other bone in her spine that's lined up, it's not lined up properly. So it's rotated, you know, which is not uncommon to get scoliosis, but it's definitely affecting my ability. Shot to, there's a discogram, which looks good. My ability to make sure we're in the right place, which I feel confident that we are at this point. Let's, you need to move your base north or something. You're way too far south. All right. Let's get an AP. That looks good. Let's go lateral. Shot. Is she okay? You have another guide wire? Thanks. Just have to clean this thing out a little bit. Yeah, it's just compacted. There we go. We're good. Take that. Okay, she doing all right? Shot. Make sure the guide wire doesn't move as we head back down. Shot. guide wire back just a little bit. Shot. Just AP. It all looks good. You can go back to a lateral view. Give me a second, I'm going to use it again. Let me just try this one more time. Release it. Shot. Shot. How rotated is her spine? Can't be that bad. Shot. 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 That's definitely the wrong way with the fluoro. Shot. 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 Okay. Shot. Okay. Shot. Can we have the table down just a 1/4 inch or 1/2 inch? Shot. Alright, I can see the dilator, the tubular retractor. Shot. Shot. Yeah. Shot. Shot. There's always a chance with any of these surgeries, fluoro out, that we can't get the herniation. Especially the more medial ones are harder to get. And what I told this patient before surgery was that we're going to try to get over as far as we can, but there's going to definitely be some left. The main purpose, though, is to get all the pressure off the nerve root that we can. So we'll start at L5-S1. That's the worst level. And even though her pain was worse at L4-5, that's back pain. Her primary complaint is her leg. She wants her leg problem fixed. So that's what we're going to work on here. You're getting that pinched nerve going down her leg, which is the left S1 nerve root. That's our main goal, is to try to get that unpinched. Come on, come on. You can see the blue dye. It's part of the herniation. Laser. I need the laser. Once again, we use this blue laser fiber, which the blue is the plastic on the outside. There's part of the herniation right there. The blue is the plastic on the outside of the glass fiber. The glass fiber is the actual laser fiber. The glass fiber transmits a laser beam of energy from a machine in the operating room that's next to the patient's feet down to the disc where I need the energy. The grabbers that I'm using are used to pull out, come on Cam, are used to pull out pieces of disc herniation that are either freed up by the laser or are, you know, still stuck a little bit, you know, inside the disc space. None of these pieces I'm getting are really giant pieces, so I'm going to have to keep using the laser, try to free things up. You can tell this is part of the herniation right here. It's really scarred and stuck down. It's not going to come out easy though. We're actually inside the L5-S1 disc space, so what I'm going to do is I'm going to start working backwards towards the surface where the herniation is its worst. As I do that, I'm going to remove more and more pieces of the herniation. You can see the pink stuff there, that's granulation tissue. I may be able to get a nice chunk of herniation out here. That looks like a piece to me. It's just stuck in there, wedged in. Let's see. Standby laser. A lot of times when I put the dilator in and the tube in, they actually push the herniation back into the disc space, and then I can just take it out in pieces, which is much safer than taking it out in the foramen. She doesn't have so much a foraminal herniation. She has what's called a paramedian, paracentral herniation, which is just off to the side of the center. Come on, man. Come on, come on. Do you not understand? It is a pinch like that. Okay? It's literally like that. Like that. Okay? Not, you know, banging against it like a battering ram. And then move your hand the next time so you don't put disc back on my grabber. The whole point is for you to take the disc fragments off the grabber, not put them back on. So if you keep grabbing where all the disc fragments are, you're going to put some back on. Is that not common sense? she's responding a bit. She's not, well, yeah, she's getting more uncomfortable, but we're going to be a while on this disc just because I have to get medial. This is all part of the herniation. This is the more lateral part of the herniation. Cam, you got to pay attention to that. It's all part of the herniation right here. Stand by. Any questions from our audience, Sonny?
Nothing yet.
Luis, do we have Grabzilla?
Oh yeah.
At some point I think I might. I can tell you this herniation's coming out in many little pieces. It's not wanting to come out as one big piece, unfortunately. Good, that was a good grab. Yeah, we don't need it yet. Take it. So I'm going to use the laser a little more. What we're seeing down here are the end plates. Those are the top of the vertebrae or bottom of the vertebrae. On the right side, you're seeing the top of S1. On the left side over there, which is right there, you're seeing the bottom of L5. And once again, the herniation is all of this material here. I'm gonna have to come out a little bit more, try to get a little more medial. See that? It's all part of the herniation. Huge mass of nucleus pulposus just stuck in there. Right where the two end plates come together in the back, that's the back of the disc. That's where the herniation is its worst. Any questions from our viewers?
No, sir.
Why am I getting bubbles? Do we have to change the solution? We're doing good? All right. So this scope that I'm using, for those of you who wonder, it's not a straight scope, it's a 20 degrees up scope. And what it does is it looks 20 degrees up towards the 12 o'clock position. Scopes in medicine come in different configurations with their lenses. And this is a 20 degree up scope. Grabber. That's part of the herniation right there that we can see. I'm getting pieces of it out. Once again, surgeons never get the whole herniation out. It's not possible. You get as much as you can, anywhere between 50 to probably 80-90% max. The goal is not to make your disc look normal. The goal is to get enough pressure off the nerve root to eliminate the symptoms of radiculopathy and to allow the nerve root to make a recovery. That's our goal. There's no surgery in the world that makes the disc look normal. Except if you were to take a dead person's disc and transfer it to your spine, which is not done yet, probably will never be done. But it's something a few countries are trying. She's starting to respond just a little bit more. I'm okay with it if you're okay with it. It's a bone spur there. I think it's about time for Grabzilla. Standby scope. Grabzilla is just a special type of pituitary grabber like the one I've been using. It's just a bit more substantial. It has a bigger mouth and kind of like my teenage daughter. She's always giving me a hard time. Especially about her phone. That's a nice big chunk, huh? Go ahead and wipe. There's a little more. Yep. Like every teenager these days, she loves her cell phone. And she did get 100 on her biology test. So I am happy about that. All right, take Grabzilla. Let's bring the scope back in. And as we remove more of the herniation, we will get a little more bleeding. Because what happens is the herniation, actually, believe it or not, it puts pressure on the blood vessels in the spine. These are little veins called Batson's plexus. And anyway, those blood vessels, they actually tend to bleed, believe it or not, when you decompress them by removing the herniation. All right. try another Grabzilla. Scope standby. Another piece of herniation there. Pretty good one, wouldn't you say? Another one. Making some progress. Getting some nice big chunks of disc herniation out. Remember, the disc herniation is at 12 o'clock, not 12 o'clock in the afternoon, 12 o'clock on the clock face for the scope. So it would be at the top there. See that area at the top? That's where the herniation is. Okay, right there. So I've been grabbing the bottom of it, its base, with the tool, the pituitary, the Grabzilla, and I've been pulling it out piece by piece. Now remember, all that herniation will be scarred in there, so I want to get out as much as I can. The laser helps remove the scar tissue and the attachments. The next disc we're doing, the L4-5, will be much easier. She doesn't have a giant scarred in herniation like she does here. Okay? You got to be careful not to expose too much medially. You don't want to have any kind of problem there. But you can see we're just behind the end plates at this point. And you can actually see all that's herniation there. Let me have the grabber, non-Grabzilla. Take that. Sometimes using the Grabzilla will free up some chunks and make it easier for the other pituitary to do its job. Yeah, right there's a nice piece of herniation. So really we're trying to remove as much of that herniation at the roof as we can. Oh yeah. And the more pieces I get out, the smaller it gets. The smaller it gets, the less pressure it puts on the nerve that's running right above it. We can't see that nerve. Oh, that's a nice chunky right there. Look at that piece. It's about the size of a pea. Like I said, the more we can get out, the greater chance we have of relieving her leg symptoms. All of these pieces are herniation. That was a huge one. And Cam's like looking at it going, wow, we're starting to have a nice little collection here going. I could feel how stuck down these pieces are, how scarred they are to the something called the posterior longitudinal ligament, which is what the nerve sits just on top of that, behind the disc. There's another piece right there. That's a biggie. Oh, that's a biggie. Oh, that's a nice one. We're going to keep them all and show the audience at the end just how. And all of this thanks to Grabzilla, right? You can see it's not just a laser surgery. There's actually surgical instruments, metal instruments, standard spine instruments that are used as well. The laser can't do it all. I'm probably about 5 minutes from being done here at this level. We still have the other one to do, which should be much quicker. How are we doing there? I think I'm going to get the laser back in here. See a little bone spur. What you can think about it is we're trying to reduce the height of the herniation, and the way we do that is by removing the base a little bit at a time, safely, within the disc. And if we do that, it shrinks over time. The herniation gets smaller and smaller and smaller. Right? During the procedure. You're doing great. Pretty much working right underneath the nerve right now that's being squashed. We're sort of just underneath it. It's right at the 12 o'clock position. These are epidural veins that are bleeding a little bit, no big deal. Very small amount of blood loss. Just looks like a lot because it's magnified. Let's see the grabber again. Laser has a lot of energy. A lot of people don't understand just how much energy the laser has. Give me a grabber. And I'm reaching over. It's a nice piece. Just about done here. These are always the hardest to get to, the ones that are L5-S1 and they're paramedian. I mean, that's not a beginning level herniation. If you're a spine surgeon wanting to do endoscopic spine surgery in the lumbar spine, L5-S1 paramedian is definitely not a starting case. I mean, foraminal is okay, foraminal herniation, but not a paramedian. It's very hard to do. Very hard. This is a paramedian. All right. That's fine. It's always best to do it when I have the grabber. Okay. I'm going to try the Grabzilla again. I think we can get a little more here. Scope off. Anything? Nope. Maybe getting to the end of the herniation at this point. Yeah, not much coming out. Probably mostly ligament at this point, which is a normal thing to have ligament. All right. Yep. Let me have the other grabber smaller. Stand by. I'm just working my pituitary right here between the two end plates at the back of the disc where the herniation is. You can see I'm able to get little pieces out. All right, laser. Let's see what else we got. A little bit of foraminal ligament, lateral recess ligament, little blood vessels, or really reaching backwards here. Hey, are you giving me the fiber good? A little bit of epidural fat right there, no big deal. The more I can debulk this herniation, the better. That's what I'm trying to do. Get out as much of it as I can. Grabber. There's a piece. All right. Let's see. Looking pretty good. She all right? One more minute. Unless I can fish out something big. Okay, laser. The thing I love about this procedure is you can get really posterior if you just redirect your tube as you start releasing the herniation. You get more mobilization of the soft tissues and the bones. You can actually get further back just under the exiting root, or traversing root, I guess you would say it. Just under the traversing root and exiting root. It's really nice. And you see how bloodless this surgery is. There's minimal to no blood loss. Just tiny little bit. All right. Well, we've gotten out as much as we can get. I think we've gotten out at least 50% of it. I'll take one more grab with a grabber. I'll do one more Grabzilla. Scope off. I think we're going to be done here with this one. Really not getting anything. So we got as much of the herniation as we can. Any questions from the audience? Sonny?
No. No questions.
I think the Grabzilla may have loosened up something in there. That's it. Smaller grabber one more time. All right, take it. We're done here. Let's take a look at the nerves, just right there. Anybody want to guess what nerve that is? We're looking up. That's the L5 nerve root. Let me see the laser one more time. Sorry. It's just so hard for me to stop. You know? They say that the enemy of good is better, but I just always want to make sure I do everything I can do while I'm here. That thing is pesky. Take it. I gotta grab that thing out. It's a hardened piece of herniation, calcified. Let's see. Laser. This will be it. So always so tempting to do more. You know, striving for perfection. Oh yeah. There's just nothing more gratifying than having a patient whose pain is gone. And I don't ever want to know that it didn't go away because I didn't do my job well. So that's why I linger, just to make it better. Unfortunately, our patient is asleep, so we can't ask her. But we will in the recovery area, that's for sure. All right. Very, very scarred in herniation, by the way. Look at how just scarred in that thing is. Just all that thick, tough material. The laser has a hard time. I mean, no surgical instrument will do better than the laser. But the laser, even the laser, struggles with very collagenized herniations, scarred in herniations. So, okie doke. I think we're good. Laser off. We've seen the roots; they look good. Get this. Off scope. And we're going to move on to the next one, which is L4-5. I'm going to take this out. You have the little roll? Yep. I do apply some pressure. Let's get the fluoro back in for a lateral view. We're doing, always put pressure on the muscles. You don't want a hematoma developing in the muscle. It doesn't take much. We're not talking about an arterial hematoma, of course, talking about a venous. And venous hematomas can do a lot of dissecting in muscle, especially if somebody who's relaxed. You can actually make a sizable clot. Of course, an artery clot would be even bigger, but those are very, very rare. But just about every patient that has this surgery in their lower back is going to have some blood in their muscle. Careful, you don't have to quickly come up. All right, is that where, show us where we are there. All right, so drop your fluoro all the way and correct this orbit thing. Because 4-5 is not as rotated as 5-1 was. Drop your side more. And let's get a shot. Bring the table up, I guess. He wants the table up. Quickly. All right. Cam, put your pressure here. You know how much pressure to put, right? Not that much. Okay. I'll get the guide wire. So we're gonna go fix L4-5 next. We've already tested it. It was definitely causing pain, back pain for this young lady, and it was I think a 9 out of 10. Shot. Good. Now I'm gonna take this needle out. She's still asleep. No. I'm telling the audience that she's still asleep. We're not going to wake her up in between the levels that we're treating. Hey, where's your roll? Because you took it off too early. Put it back here. Yeah, just because I'm starting to work here doesn't mean you stop. Okay, just don't block my way. You can feel the dorsal fascia. Shot. Why can I barely see this? Are you all the way to the ground? Putting pressure. Let's get the table up, please. And shot. All right. Come off, Cam. All right. Let's see what we got. Shot. Okay. It's looking good. Shot. Mallet. Shot. That's it right there. Shot. What? Come on, man. Know the right one. Be confident. Know what you're doing. Shot. Jordan, I don't know what you're doing with the fluoro, but I need an accurate lateral. Drop your fluoro a little bit. Drop the table. 1/4 inch. Get an AP. I mean, look how that's changed everything right there. Jesus Christ. Hold on. Shot. Yeah, we're out. It's the second time. Go back to a lateral, Jordan. You gotta get your lateral set up properly. Take this. Come on. You guys are getting me distracted, and it's really frustrating. Do what you need to do properly so I can do what I have to do properly, okay? That's what a team means. Jordan, are you not able to see that that's not a true lateral? That's why you want to do all that and get it right before we have to add discogram dye, because it changes everything. Makes it a lot harder to see. Put pressure here. Fucking unreal. Jordan, what are you doing? Huh? I can't hear you. I'm waiting for you to get it. I'm not sure what you're doing. Let me have a blue towel. Jordan, are you done or what? That's terrible. Huh? Yeah. Release this. Shot. All right, lock that in. Come out. Shot. 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 Move out, please. Grab her. Probably 5 more minutes. Stand by. Good job, Cam. Don't drop that thing. I'd say 4 minutes, assuming everything goes well. I don't know why I can't roll it. Are you holding the wire? You free up on the laser fiber? Remember, it needs to arc through the air, so this is definitely all scarred up right here.
I have a question.
Sure.
Magnus on Facebook is asking, are those shots taken with just X-ray?
Sonny, I heard you talking, but I honestly didn't hear the question.
Sorry about that.
Could you repeat it?
Yeah, it's Magnus from Facebook is asking
Magnus, all right.
if those shots are
Yes,
taken with
Magnus.
just X-ray.
What's the question?
Are those shots taken with just X-ray? Let me try this again. Are those shots taken with just X-ray?
Are those shots taken with just X-ray? So the X-ray shots are the ones we were taking earlier. What you're watching right now is the actual laser and the endoscope. You're looking through a tube with a camera and lenses. So this is not X-ray that you're seeing right now. Sonny, you have them on the scope, right? The scope feed?
Yeah.
Yeah. Right now we're broadcasting the endoscope feed, the same thing I'm seeing. If you see a little blue fiber, that's the laser fiber. The earlier pictures where we were trying to get the needle back into the disc space, those were done with a X-ray machine. And X-ray machines are, these days, they're not very helpful at figuring out where pain comes from. They're good for navigating. So spine surgeons use X-rays to navigate. Kind of like using the stars at night to navigate to your destination. That's why we call it navigating. You're navigating. It's not through the ocean, not over land, but you're navigating through the body, the human body. All right. Another minute, and we're done. We're actually in the foramen right now. That's what you're all seeing. It's pretty cool, huh? There's a nerve root up there, but it's covered in fat. All right, we're pretty much done here. Laser off. Let's get the lights on, and we will show you. You have the roll. All right, everybody see this? The Magnus, you see this? This is the endoscope, the tube, everything's done through here. This is actually the endoscope. This is the endoscopic tube, or we call it a tubular retractor. So yeah, Cam's done a good job here. Can you guys see the herniations? All these pieces?
Yes, sir.
That's what we got out. We're going to send those off to the pathologist. I'm going to pull the tube. Go ahead and put pressure now. No, right, not on this incision, but just, yeah. All right. Oh, probably lost 10 mils of blood. I'll show you the incision. Cam's doing a little pressure right now. Let's see. Keep your pressure here. Right there. All right, make it 15 mils. Okay. The incision's there. What's bleeding is venous bleeding, very common. So go ahead and turn this like this and just put pressure there for about 4 minutes, okay? And then recheck it and then put pressure again. Okie doke. You getting the fiber? Yes, sir. All right, 4 minutes of pressure. Any questions? I got a Raytech off the field here in the garbage.
No, sir.
Okay. Well, we've completed a Duke laser disc repair, L4-5, L5-S1, for herniated discs at L4-5, L5-S1, in a patient with mostly leg symptoms on the left side, down her left leg. She had really bad pain when she presented, and now she's got like numbness and her leg feels dead. So our goal is to restore feeling to the leg, EBL 15 mil, and to treat her back pain, which we know she has from those 2 herniated discs. If you have questions, feel free to type them up and I'll do my best to answer them. Good job, everyone. Once again, thank you. And good afternoon. This is Dr. Deukmedjian, CEO and founder of Duke Spine Institute, here with Sunny. And Sunny and I are doing the broadcast of the surgery today from Duke Spine Institute live. If you're watching on October 22nd, 2020, you've just witnessed 2 surgeries this morning. The first was a Duke laser disc repair endoscopic surgery, L5-S1, on a gentleman with bad back pain, and now we've completed just now a 2-level Duke laser disc repair, L4-5, L5-S1 for herniated disc L4-5, herniated disc L5-S1 with nerve root impingement and compression. Now this was a huge disc herniation at L5-S1 and it was really scarred in. This poor patient's had back pain, leg pain, and the pain has turned now into numbness in her legs, so where she can't feel her leg. She just presented with an MRI with a massive herniation that was scarred down at L5-S1 and a smaller herniation at 4-5. She has back pain at both levels. We tested during the surgery with a discogram and found that she had pain. So we just wrapped up the surgery, single incision. We fixed both discs with endoscopic transforaminal surgery using the Duke laser disc repair technique, which is basically a decompressive discectomy at L5-S1 in this case, and then an annular debridement with discectomy at L4-5 as well as at L5-S1 with the annular debridement. The annular debridement is essential to getting rid of the back pain and allowing the disc to heal properly. Our patient should go home in about an hour, and yeah, everything went well, pretty much what we expected to find. And we'll take any last questions if you have any. Otherwise, we'll see you back in a few weeks when I get back into town. I have some business to attend to. It's called the World Championship.